Hi there, Dr. Avinash here. This time we are talking about a very important topic, which is drug therapy of migraine. So, what is migraine? We don't know exactly what happens in this disease. This is kind of a mysterious disorder, but the patient complains of pulsating headaches. And surprisingly, it is only on one side of the head, so it's like right sided or left sided. And then this headache will last anywhere between 4 to 48 hours. The patient also tells you that he has symptoms like nausea, vomiting, photophobia, that is sensitivity to light, sensitivity to sound. So there's phonophobia and photophobia. There are flashes of light that the patient can see. He has vertigo, loose motions, and many other symptoms are there. Now, there are two types of migraine. One is called as migraine with aura, also known as the classical migraine, and then we have the migraine without aura, which is called as the common migraine. The classical migraine has an aura. Aura means before the headache starts, there is some visual or neurological symptoms like the ones which I had spoken about, right? Flashes of light, nausea, vomiting, photophobia, something like that happens. The patient knows that he is about to get a migraine. Common migraine does not have this aura. Okay. Why it happens? Again, we don't know reason. We know what exactly happens. We know that there is pulsatile dilatation of large cranial vessels which causes pain. Okay. Now, what we think happens is this. There is a theory called as the vascular theory. Okay. Now, this is what we think happens. There is initial vasoconstriction or shunting of blood through the carotid arteriovenous anastomosis. So what happens is either there is vasoconstriction because of some reason which we don't know, or the blood from the carotid arterial system directly jumps to the venous system. So the brain does not get enough oxygen. There is cerebral ischemia and that starts to attack. This is one theory that we have. The second theory is called as neurogenic theory. What is believed is there is a spreading depression of cortical electrical activity. So it is suggested that the neurons are stopping their activity, and this is then followed by vascular phenomena where there is less blood going to the brain. We don't know what is the triggering event. Okay, but some triggering event is there which produces neurogenic inflammation of the affected blood vessels. Now this is neurogenic inflammation because of neurons. How? We don't know. It's like the nerves are controlling the inflammation, and this is amplified by or exaggerated by retrograde transmission. So instead of bringing the message towards the blood vessels, there is retrograde transmission in afferent nerves. Okay, and that releases mediators like serotonin, neurokinin, substance P. We also have something called a CGRP, calcitonin gene related peptide, nitric oxide, and all these chemical mediators that causes perivascular edema. Now, why will that happen? There's leakage of plasma from the inflamed cranial vessels and pain. So edema and pain happens because of this release of mediators, and the pain is also because of nerve endings in the dura mater. It is suggested that as these blood vessels dilate, there's stretching of the dura mater, and that causes pain. Which theory works? Vascular theory, neurogenic theory? We have no clue. Okay, maybe both work. Maybe all these mediators are important, maybe none of them are important. We don't know. But we have noticed one very interesting finding, and the finding is in the blood or in the urine, the levels of serotonin and its metabolites change. Clear? Actually, it increases. So it is suggested that maybe migraine is because of serotonin release. So with this theory in mind, maybe see in urine your serotonin levels are increasing, blood urine serotonin level, its metabolites are increasing. So what scientists did was they gave certain medications that release serotonin, and patients got migraine. See, it's confirmatory now. I give a medicine that releases serotonin, migraine happens, which means serotonin does play a role in pathogenesis of migraine. We also did another experiment. When people suffered from migraine, we gave anti-serotonin drugs. Clear? And we did this and we noticed that the patients kind of have a better, kind of recovery. So keeping all these things in mind, it appears as if serotonin is the main role player here. It has a pivotal role. That's what we'll call it. Simple. So does this example, does this reasoning, does this experiment fit to all? Nope, not at all. Every single individual is unique. In some people, serotonin might be the main player, in others, something else might be the main player. And that's the reason why the drug therapy of migraine has to be individualized. There is no one standard treatment protocol. I can't be like, do this, and patient will be fine. No, that's not possible. Clear? How frequently the attacks are, how severe the attacks are, how is the patient responding to your medicine, all of them will decide what medicines you give, in what doses you will give. Commonly, this is what we will do. If it is a mild migraine, you give simple analgesics, non-steroidal anti-inflammatory drugs, maybe combine some non-steroidal anti-inflammatory drugs, give an antiemetic if the patient is vomiting, getting it simple. If there is moderate severity of pain, then you will give non-steroidal drug plus a medicine called as a triptan. Okay, actually what you do is combine non-steroidal anti-inflammatory drugs, or you give a triptan, or you give an ergot alkaloid. So one of the three, non-steroidals, triptans, or ergot alkaloids, one of them you give, plus antiemetic if the patient is vomiting. If there is severe headache, then non-steroidal drugs don't work that good. So here you either start only with a triptan or an ergot alkaloid, add antiemetic if necessary, and after the attack of migraine goes away, you will give prophylaxis. Prophylaxis can be done by one of the 4 drugs, propranolol or any other beta blocker, amitriptyline or any other tricyclic antidepressant, flunarizine or calcium channel blockers, and valproate or topiramate, something like that. So this is the basic plan. Now as you go through this write up, you will notice that more or less same thing has been mentioned. What is mild migraine? Well, a case fewer than 1 attack per month, but that headache is less than or up to 8 hours. The headache is tolerable and does not incapacitate the individual. It's not like the patient has to be bedridden because there is headache. Then I will call it mild migraine. Remember, less than or 1 attack per month, tolerable headache, maximum time allowed is 8 hours, and does not incapacitate. That's mild. Give simple analgesics like paracetamol or aspirin. The moment they start getting headache, they should take paracetamol or aspirin. Okay, and repeat after 4 to 6 hours. Okay, most of the time the attack will not even happen, or will not become full-fledged, or it will stop. Non-steroidal anti-inflammatory drug or the combinations can be used: ibuprofen, naproxen, diclofenac, mefenamic acid, indomethacin. Either single drugs you can give, or you can give a combination, it doesn't matter. You can combine non-steroidal drugs with paracetamol, you can give it with codeine, you can give it with diazepam, any other sedative, diphenhydramine, you can give it with antihistaminic, you can give it with caffeine. See, many combinations are available, and as I said, each therapy, each patient is unique, therapy should be unique. You need to find the ideal combination for your patient. Okay. You need faster action, so you use dispersible or effervescent formulation, because kind of absorption becomes faster. During migraine there is gastric stasis, so maybe the regular tablet will not even get absorbed properly. So give this dispersible one, works pretty good. Analgesics would work amazing if there is migraine without aura. But then again, see, people with migraine and aura, they might take this anti-migraine drugs. Okay, plus these non-steroidal combinations. You can give it. Rule: start the medicine as early as possible. So the patient has to be explained the moment you start getting headaches, start. Second, stop it after the attack passes off. Okay, if you give too many of these medicines, it itself can cause headache. Okay, so the moment prodromal stage starts, it's like the initial state, take it. Okay, so that is good. But then again, you explain to the patient that since you are having mild migraine, there's no point in taking it lifelong or something like that, just as and when needed basis. Antiemetics might be necessary. Gastric stasis occurs, as I just mentioned. It will delay the absorption of oral drugs. So what you do is give metoclopramide. So what metoclopramide does is it relieves the nausea, vomiting and gastric stasis. And if it is like, see, if the patient has already started vomiting, then you will give injections. Clear? Few of the antiemetics that you should know at this point of time is domperidone, prochlorperazine. They are also effective. Okay, and if you want, see, many medications can be given which will kind of make the patient a little drowsy. If the patient has migraine, it is a good idea to make the patient sleep, right? So diphenhydramine, promethazine can also be given at the same time. Easy. So if somebody asks you what is the treatment of mild migraine, explain what is mild migraine. Start with simple analgesic, non-steroidal anti-inflammatory drug combinations and antiemetics. That should be it. Simple. Now if it is moderate migraine, well, what is moderate migraine? Throbbing headache, more intense than the mild one, lasts for 6 to 24 hours. There's usually nausea, vomiting and other features which are very, very prominent, and the patient can't really function properly. Plus more than one attacks per month, more than one attack per month. Here simple analgesics might not be great. Stronger non-steroidal anti-inflammatory drugs plus their combinations can be given. Which combinations? The one which we mentioned in the mild ones. Okay, most of them will recover. Who do not recover, you will give them anti-migraine drugs such as triptan or an ergot alkaloid. Simple. Now what are these triptans and ergot alkaloid? We'll come to that, don't worry. Plus antiemetic should be given. If the patient has 2-3 attacks, 4 attacks, 5 attacks per month, then prophylactic therapy is advised, otherwise not necessary. A severe migraine is a patient who suffers more than 2 or 3 attacks per month. Severe throbbing headache, 12 to 48 hours of headaches. There's vertigo, vomiting, many other symptoms, and the patient can't even get up from the bed. He's grossly incapacitated. Getting it? Simple. So here those non-steroidal anti-inflammatory drugs and NSAIDs will not even, the analgesics will not work. So here you have to give specific anti-migraine drug along with antiemetic. Simple. So you can try longer acting analgesic like naproxen with a triptan. Simple. Prophylactic should be given for 6 months or more, and then once you are sure that the patient has kind of not had an attack for quite a long time, you might try to stop it. Easy. So we spoke about medicines such as triptans and ergot alkaloids. So let me help you out with what is ergot alkaloids. Ergot alkaloids, basically we get these medicines from a fungus, an ergot fungus, Claviceps purpura. There are many types of ergot alkaloids. Ergotamine is the most effective ergot alkaloid for migraine. You give it early in the attack, lower dose, great. The patient will get dramatic relief. But when the pain becomes very severe, then you will have to give larger doses. And once the pain has set in, getting rid of the pain takes some time. So control will be achieved only after a few hours. Because you want faster action, you try to give a oral or sublingual route 1 mg, half hour interval till relief is obtained, or total maximum 6 mg. See, it's like this patient starts having migraine at 11 o'clock in the morning. So you'll get 1 mg at 11 o'clock, 1 mg at 11:30, 1 mg at 12 o'clock, 12:30, 1:30. See, how many doses can you give maximum? 6. Now you might be wondering, if you want faster action, why not give injections? Well, injections are not that recommended because it has a lot of side effects. It's more hazardous. So ergotamine should be not given parenterally. So how does it work? Remember, there was vasoconstriction followed by dilatation of the cranial blood vessel, which was causing pain. Ergotamine constricts the dilated cranial vessels. Okay, and surprisingly, if there is a abnormal connection between carotid arteries and the venous system of the cranium, then the constriction of the carotid AV shunts happen. So the shunts stop. So the blood goes to the brain. The brain does not get ischemia. Simple. Now there is there's a related drug called as dihydroergotamine. What we have noticed is both these medicine reduce neurogenic inflammation and leakage of plasma in the dura mater. So if leakage does not happen, the dura mater does not get stretched. If the dura mater does not get stretched, then of course there will be no pain, there will be no perivascular inflammation also. Okay. How does it work? Well, it is thought to work through the partial agonism at the 5-HT1D1B receptor around the cranial blood vessels. Easy to understand. Dihydroergotamine is almost as effective as ergotamine, but it is the preferred parenteral route because it is less hazardous. So if you want to give oral, it's ergotamine. Dihydroergotamine is injection. So in our clinical practice, where do these drugs stand in the treatment of migraine? Well, the problem with this drug is they have erratic oral absorption. There are many side effects like nausea, vomiting, muscle cramps. And now we have better drugs called as triptans, which we'll be discussing in 2 minutes time. Ergot preparations are not used except when people are like, triptans are too costly, or when triptans fail, then we can use them. They don't have prophylactic value, so don't give them regularly. And what we have noticed is too much triptan can produce a dull background headache. And we have noticed that when you stop giving, not triptans, ergotamine, so they can give you a headache. And when you stop giving ergotamine, dihydroergotamine, we have noticed that there might be an attack of migraine. It can be precipitated. If you want a better absorption, caffeine 100 mg along with ergotamine enhances absorption both from oral and rectal route. So caffeine can be combined with ergotamine given orally, or caffeine ergotamine rectal, and it will kind of help. Clear? Simple. Many combinations are available. The brand really does not matter. Easy enough, simple, perfect. The second migraine specific drug that you need to know is triptan. Now what are triptans? These are selective 5-HT1D1B agonists. Simple. A very novel class of medications. They activate the receptors 5-HT1D1B, and they are the first line drugs for all those patients who fail to respond to other analgesics. Now that's the reason why ergots, we don't use them now. The way these drugs have been designed, they work only on one subtype of serotonin receptor. Okay, and because we have made a medicine that works on a specific receptor, there's hardly any difference between the various triptans. Okay, action wise, pharmacodynamically speaking, Pharmacokinetic differences are almost always there. Okay, all triptans will have much better bioavailability than the prototype drug, which is sumatriptan. We'll talk about that a little bit. And we have noticed that when people take triptans, there are fewer headache recurrences. Okay, especially when the patient has taken naratriptan and frovatriptan. This is because both these medicines have a longer THAF. Okay, but they're kind of slow to start their action, so they're slower in getting the patient some relief from the pain. Let's discuss the prototype drug, sumatriptan. This can be a short answer, so you need to know this. This is first selective 5-HT 1D1B receptor agonist. First of its kind, it activates only specific subtypes of 5-HT1 receptor, okay, which is 1D1B. But if given higher concentration, it can activate many other serotonin receptor. But important MCQ, does not interact with 5-HT2, 5-HT3, 5-HT4 to 7 receptors, nor does it act on alpha beta adrenergic receptor, not on dopamine, not on cholinergic or GABA receptor. So it's very, very specific. Okay, it works on 5-HT1, to be precise 1D, 1B and other subtypes of 5-HT1 at high concentration. You need to remember this. Okay, when given at the start of migraine, it's very effective and it is much better tolerated than ergotamine. 75% people, 3 out of 4 people will tell you within 2 to 3 hours the headache is gone. But problem is within 24 hours, almost 20 to 40% people might complain of headache. Maybe because half-life is small. Good thing about sumatriptan, suppresses nausea and vomiting of migraine, but ergotamine, if you recall, increases nausea and vomiting in migraine. Okay, now because it is so specific to 5-HT1D1B receptor, migraine vanishes, it goes away, because these receptors constrict the dilated cranial blood vessels, especially the arteriovenous shunt in the carotid artery. They are blocked, getting it? So the moment these shunt vessels get blocked, the brain continues to get oxygen. There's no edema, there's no neurogenic inflammation, there is no headache. That's the plan. Okay, so in a case of migraine, the dilated blood vessels divert the blood away from the brain, but when you kind of constrict them, the pain goes away. Okay, now you might be wondering, when we spoke about the pathophysiology of migraine, we said serotonin is the cause of migraine. It causes dilatation of blood vessels. Then we are giving ergotamine and triptans. These are also acting on serotonin receptors. How are they causing vasoconstriction? Actually, 5-HT1B, 1D receptors, 1D, 1B receptors are presynaptic autoreceptors. And if you recall, autoreceptors reduce the release of neurotransmitter. Clear? So by acting on autoreceptor, the level of serotonin decreases. Getting it? And that's how they work. Plus, maybe, we don't know, in addition to whatever action I just spoke, it inhibits inhibitory neuropeptide release around the affected blood vessels, and as a result the dural blood vessels don't leak plasma, they don't become inflamed. Simple. So this neurogenic inflammation of cranial blood vessel is suppressed. Clear? Rule: use triptans to treating acute attack of moderate to severe migraine, not responding to other medicines like analgesics and their combination. You need to know this. They are not for everyone and anyone. You give analgesics first. If they don't work, then you move to triptans. If triptans are too costly for your patient, then you move to ergotamine, dihydroergotamine. Simple. As far as pharmacokinetics is concerned, very nicely absorbed even after subcutaneous route. sorry, you give it by subcutaneous route, very nicely absorbed. Oral absorption is hardly 15%. Okay, but we have now started developing an intranasal spray. Doesn't work that good, but yeah, we are developing it. This is the only triptan that we have made available for nasal and parenteral administration, plus oral, of course. All the other ones are more for oral. Sumatriptan very easily metabolized by an enzyme MCQ, MAO-A, monoamine oxidase A isoenzymes. Okay, side effects are mild. Okay, many people complain of tightness in head and chest, feeling of heat, like the body is warming up. Many people complain of paresthesias, like tingling and numbness or something like that. Okay, dizziness, weakness, but they're short lasting, dose limited. Okay, and more common with subcutaneous. Subcutaneous injection is painful also. Simple. A little rise in blood pressure occurs, but that does not really matter. Again, because sumatriptan is not to be given daily. Other things that we have noticed is bradycardia, coronary vasospasm sometimes happens. There's a risk of myocardial infarction, serious consequences of giving the medicine, but these are very infrequent. Of course, some sudden deaths have been reported. Seizures might happen, hypersensitivity can happen, but they are pretty rare. The only contraindication, and this is important, is ischemic heart disease, hypertension, epilepsy, hepatic or renal failure, or impairment, pregnancy. And patient should be told, please don't drive. Okay. Another rule, triptans and ergotamine should not be given within 24 hours of each other. They might cause problems. Okay, another thing is, don't give it with other drugs that act on serotonin, like serotonin reuptake inhibitors, MAO inhibitors, lithium. So don't getting it. Now compare this with rizatriptan. This is more potent, has a higher oral bioavailability and a faster onset of action, and hence rizatriptan can be given. Then in this box they've given you sumatriptan, frovatriptan, rizatriptan, naratriptan, and zolmitriptan. Do you need to know them? Not really, but again, like if you're interested in acing your exams to a different level where you need to be like at the top of your class, then maybe you should go through this table. Otherwise, it's an okay to know table. Now, once a patient gets migraine, the next question he will ask you is, this headache was so horrible, I don't want to get it again. What can I do? See, if it's mild, you tell the patient, check it. Not worth taking medicines daily for a headache that will happen less than once a month. Plus, it's not really incapacitating. It's a tolerable headache, right? And we can manage it. So, no need of giving prophylaxis for a mild migraine. But if the patient has moderate to severe migraine, like 2 or 3 attacks per month, more than that, or despite giving the best possible treatment available, the patient says, I am incapacitated, I am disabled during the attack, the patient has to be in the bed, can't leave his house, can't do any work. Or the patient who has contraindications for triptans and ergotamine, then you better not have a patient with migraine. Getting it? Like, it's logical to prevent migraine from happening, because the number 1, number 2 drugs for migraine are contraindicated. So then prophylaxis becomes important. What is that miracle medicine for prophylaxis? There's no miracle medicine. There are diverse classes of drugs that are used. None of them are 100% effective. None of them abolishes the attack totally, but it's like kind of chances reduce, so we give it. Another thing is, if for 6 months patient has not had attack of migraine, you stop the drug and see whether you need to continue it or not. And many patients with migraine know the precipitating factor that causes migraine. Now, once we start with medicine, there's a very beautiful statement given in medicine textbooks. Everything under the sun, including the sun, can cause migraine. There's no one reason for migraine. Anything, tea, coffee, washing face, taking a bath, new perfume, sunlight, darkness, anything can cause migraine. A patient knows what is his or her trigger factor. Try to avoid that. That's the minimum thing that they can do, right? But if they want prophylaxis, we can give beta blockers such as propranolol, commonly used drug. It reduces the frequency and severity of attack in almost 70% patients. Clear? Now, if you start it today, it takes around 4 weeks for um, the effect to be seen, and till the time you are giving the therapy, the effect is there. Start with a dose of 40 mg twice a day, increase up to 160 mg twice a day if required. How it works, we don't know. Maybe beta blocker, kind of. We don't know exactly. Like, there are quite a lot of research which says this is bullshit, it does not work that way, but might be, we don't know. There are other non-selective beta blockers such as timolol, beta 1 selective metoprolol, atenolol, which are also effective. Okay, but there are if you recall from your autonomic nervous system, there are medicines like pindolol which have intrinsic sympathomimetic action. They're not at all useful. So give propranolol, timolol, metoprolol, atenolol. These are effective ones. Second category is antidepressant. Amitriptyline is used mostly, and it does reduce migraine attack. It's effective in patients but has side effects as compared to propranolol. When we go to tricyclic antidepressant unit, we will realize that these antidepressants block the reuptake of serotonin. Whether that is the reason it gets a prophylactic effect, or is there any other action, we don't know. Maybe it is the reuptake blocking property. Okay, it's not like a more powerful antidepressant is a more powerful anti-migraine drug. Not really like that. The anti-migraine action is independent of antidepressant property. But then again, see, patients who are suffering from depression and have migraine, you give them antidepressants, it makes more sense, right? Like, why would you give an antidepressant to a patient who is happy, healthy, and has migraine? Getting it right. So these are for selected patients. CCBs, calcium channel blockers, verapamil, blocks migraine attack, but it is less kind of effective as compared to propranolol. Then we have flunarizine. This is actually a very weak calcium channel blocker, but it also inhibits sodium channel, so it's as effective as propranolol. That's what they are saying, but whether there's a proof or not for that, let's not debate that. The frequency of attack is reduced, but then again, see, the intensity, the duration, whether it changes, that we don't know. It is suggested that, again, like, we don't know whether it really is true or not. It is claimed to be a cerebroselective calcium channel blocker. So by reducing intracellular calcium overload that happens during brain hypoxia and many other causes, which causes that neurogenic inflammation, calcium channel blocker actually prevents this intracellular overload. So neurogenic inflammation does not happen. Side effects are there: sedation, constipation, dry mouth, hypotension, flushing. Many people have complained of weight gain and sometimes extrapyramidal side effects. So that's the reason why flunarizine is not like the favorite one. We have also tried some anticonvulsants such as valproic acid and gabapentin. They do have some prophylactic effect. We also have a new drug, topiramate, for migraine prophylaxis. 50% attacks get reduced in 50% of the patient. Getting it? So 50% patients will have 50% lesser attacks. The idea is to start with topiramate 25 mg once a day, gradually increase it to 50 mg once a day or twice a day. Is it as effective as propranolol? Not at all. So this is to be given in patients who do not tolerate propranolol, who have contraindication to propranolol. The CGRP antagonist, you just need to know the name. This is like highly costly drug, once a month medication, like you inject it and forget it. Erinumab, that's the name of the drug. And then there are 5-HT antagonists, methysergide, cyproheptadine. They are not as effective as beta blockers, so we are not going to use them for migraine. So this is it, drug therapy for migraine. Go through it, let me know if there's any doubt. I will be more than happy to help you. Till the next time we meet, this is Dr. Avinash signing off for now. Take care, keep studying and keep rocking. Bye bye.